Hello everyone. Today we will discuss reactions in leprosy. Introduction. Reactions are acute inflammatory episode superimposed on a relatively uneventful, unusual course of the leprosy. They are generally acute hypersensitivity reactions to bacillary antigens. Type 1 reactions mainly occur in a borderline spectrum, although few with the polar forms may also experience type 1 reactions, and about 30% of individuals with borderline disease experience a type 1 reaction at some point during the disease course. Type 1 reactions may be upgrading, reversal reactions, or a downgrading, which means they may upgrade it towards tuberculosis and may downgrade to lepromatous leprosy. In lepromatous group, lepromatous leprosy or borderline leprosy, there may occur erythema nodosum leprosum or a type 2 reactions, Lucio phenomenon, and acute exacerbation of existing disease. Type 1 reaction, type 1 leprosy reaction. Type 1 may be a presenting feature of the disease or may occur during the course of the treatment or even after the treatment has been completed. The reactions are frequently recurrent, leading to further nerve damage. Type 1 reaction is a delayed type hypersensitivity reaction, which is an example of Coombs and Gell type 4 hypersensitivity reaction. Antigens from a degenerating leprosy bacilli interact with the T lymphocytes. This is associated with a rapid change in cell-mediated immunity. Upgrading or a reversal reaction. Type 1 reactions are typically seen in borderline patients, which are most unstable forms of leprosy because of their immunological instability, and if the reaction is associated with a rapid increase in specific cell-mediated immunity. As it is in patients under treatment, we speak of upgrading or reversal reactions. This is because of the natural tendency of the borderline leprosy to downgrade slowly towards the lepromatous pole in the absence of treatment, or it is reversed. Whereas in downgrading reactions, if the reaction is associated with a reduction in immunity, we speak of downgrading reaction. Decreased reduction in immunity leading towards the lepromatous pole. During the normal course of leprosy, downgrading is more frequent than upgrading, but it is commonly silent without a reaction. However, the number of downgrading reactions is not insignificant. Such reactions do not attain the maximum severity, but they may be sufficiently severe to cause a clinical confusion as to the nature of the event. Downgrading reaction is a distinct reaction that occurs without treatment, which they are converted to lepromatous leprosy pole. Downgrading reactions can occasionally be associated with resistance, making it diagnosed with important implications. The various shifts across the leprosy spectrum in an upgrading type 1 reactions, in which the lepromatous pole converted to tuberculoid pole, as lepromatous leprosy to borderline leprosy, borderline tuberculoid, and tuberculoid. Lepromatous leprosy pole and a tuberculoid pole are the most immunologically stable form. The reverse holds good in downgrading reactions. Downgrading means in which they are converted to lepromatous leprosy. Borderline tuberculoid, borderline lepromatous, and lepromatous leprosy. In which upgrading type 1 reactions are lepromatous leprosy are converted to tuberculoid. As in downgrading reactions, tuberculoid form converted to lepromatous leprosy, in which where the lepromatous leprosy the immunity is decreased cell-mediated immunity, whereas in tuberculoid forms there is a increased cell-mediated immunity. Prevalence varies from 8 to 33% for all the leprosy patients. In borderline tuberculoid and borderline patients, most likely time for upgrading reactions because they are the most immunologically unstable. Times for upgrading reactions to occur in between 2 weeks to 6 months of treatment, but longer intervals have been recorded in borderline lepromatous leprosy. About 50% of borderline patients will get type 1 reactions, usually between 2 and 12 months after the starting chemotherapy, but sometimes later if they had previously downgraded almost to lepromatous. Untreated borderline tuberculosis patients may suffer episodes of type 1 reaction in association with downgrading, presumably because the immunological balance is responding to increasing antigenic stimulus. The factors that upset immunological balance and precipitate reactions include pregnancy, intercurrent infections, especially tuberculosis, vaccinations, psychological stress, HIV, immunological reconstitution, inflammatory syndrome, and immunosuppressive therapy. Recently, resistance has been described as a trigger. Etiopathogens and risk factors. The reactions appear to arise as a result of absolute increase in the level of delayed type hypersensitivity in the early stage of the clinical disease. A disequilibrium between the local and general level of antigen in hypersensitive patients may determine the onset of reaction, as in nerves. The sudden unmasking of pocket of bacterial antigens in a nerve trunk or a dermal bundles in a patient with least some residual delay type hypersensitivity may elicit a local delay type hypersensitivity response. Risk factors for type 1 reactions. It may occur during MDT or subsequent of 6 months of MDT or a positive bacillary index in multibacillary cases. Extensive disease indicated by the number of body areas involved and borderline classification. Nerve function impairment or WHO disability grade type 1 and 2 presented in diagnosis. Having a facial patches as a risk factor for lag of thalamus. Pregnancy, bactericidal drug regimens, enlarged ulnar nerve at the diagnosis, attending as a self-reporting case, presence of anti-phenolic glycolipid 1 antibodies and a positive lepromin test, which is strongly positive in borderline tuberculosis, whereas it is negative in lepromatous leprosy and BCG vaccination. Nerve function is impaired by a local ischemia secondary to compression of the perineural blood vessels by the inflammatory edema and a direct destruction of Schwann cells and axons by CD4 T cell mediated granulomatous process. So, edema regularly accompanies the cutaneous leprosy lesions, and it has been invoked as a potential mechanism of injury to the peripheral nerves. No formal measurement of endoneural pressure have been done in leprosy to document increased pressure or edema. Although surgeons who operate on patients with acute lepromatous neuritis describe the procedure as decompression, the inevitable post-inflammatory fibrosis ultimately leads to irreversible nerve damage. The mechanism of nerve damage due to local edema and a granuloma in a type 1 reaction and consequential fibrosis, in which granuloma damaging the skin structure and a reactional edema. Immunological and mechanical factors involved in nerve damage, in which edema in this perineurium, it is a rigid layer which can't expand, leading to axonal compression and interruption of intra-axonal flow, and in perineurium edema leading to pressure on venules, engorgement of the capillaries by back pressure here, compression on venules leading to venostatic edema, diffuse subacute and segmental demyelination leading to subsequent fibroblast activation leading to fibrosis. See, edema in a perineurium, which is a rigid layer which can't expand, leading to pressure on venules, engorgement of the capillaries by back pressure, leading to venostatic edema. Clinical features. Clinically, the most prominent sign is a rapidly developing change in the appearance of some or all the skin lesions, which become erythematous, edematous, more prominent, shiny, warm to touch, and may resemble erysipelas. Sometimes necrosis supervenes with a breakdown and ulceration, and the term Lazarin leprosy has been possibly incorrectly ascribed to this in the past. Appearance of new lesions may also be seen more commonly in a downgrading reaction, in which tuberculosis is converting into lepromatous leprosy. BT Hansen's with a marked edema in a plaque during a type 1 reaction. In borderline leprosy, Hansen's with a subsiding type 1 upgrading reaction showing a scaly erythematous plaques. This patient also had neuritis of ulnar nerve. Psoriasiform type 1 reaction with intense scaling and edematous plaque. Difference between a type 1 upgrading and downgrading reaction. Upgrading reversal reaction. Reversal reaction usually occur during the first 6 months of therapy in borderline tuberculosis and borderline patients, but longer intervals have been observed in borderline leprosy patients. Alteration in cell mediated immunity, increased in cell mediated immunity. Whereas in downgrading reaction, it is seen either in patients no treatment or who have interrupted the treatment, in which tuberculoid forms are converted into lepromatous leprosy, where there is a decrease in cell mediated immunity. Features. Some or all the existing leprosy lesions show signs of acute inflammation. They are pain, tenderness, erythema, and edema. Necrosis and ulceration occur in severe cases. Lesions discommate as they subside. New lesions might appear occasionally, whereas in downgrading reactions, lesions worsen and the morphology of the existing lesions and new lesions become more in lepromatous. Neuritis is often marked. Neuritis is often less marked. Here it is due to increased cell mediated immunity. Here there is a decreased immunity. In reversal reaction, there is edema. Histologically, there is edema, reduced bacilli because increased in cell mediated immunity and increased defensive cells such as lymphocytes, epithelioid cells, and giant cells. There is an increase in bacilli and decreased in defensive cells are replaced by macrophages, where there is a decreased cell mediated immunity. Steroids are needed in most of the patients. Usually just continuing the MDT is sufficient. If steroids needed, response occur with low doses than upgrading reaction. Upgrading is more severe because there is a marked immunity alteration and increased in immunity. See, this is a patient presented with a sudden erythema and edema of a pre-existing large plaque and eruption of multiple smaller plaques, smaller papules and nodules with no neuritis. And new lesions were lepromatous in appearance. She was diagnosed as BT, borderline tuberculosis, downgrading to borderline lepromatous with type 1 reaction. The patient responded to a short course of steroid along with a modified anti-leprosy treatment. As a molecular test had revealed a drug resistance, Mycobacterium leprae. This is a patient presented with edema, mainly mildly tender annular lesions on the face with macules and papules on a back. There was no neuritis or nerve function impairment. He was diagnosed as a case of borderline tuberculosis, downgrading to borderline lepromatous with type 1 downgrading reaction and responded adequately with low dose steroid 20 mg prednisolone. See, this patient has a visible annular edematous plaque with multiple barely visible papules, with which showed a bacillary index of 5 with globi. A diagnosis of borderline downgrading to lepromatous was made. The downgrading reaction is apparent at a later date, when the papules were histologically confirmed as lepromatous leprosy, establishing the downgrading reaction. Severe reactions may accompanied by systemic illness, characterized by low-grade fever, malaise, anorexia. Another associated manifestations is edema of feet, hands, face. Neuritis is the most important part of type 1 reaction. Concomitantly with the skin involvement or even independently, possibly reflecting hypersensitivity to different antigens with different antigens of Mycobacterium leprae as mentioned before. This takes the form of rapid swelling of one or more nerve with a pain and tenderness at the site of nerve swelling, usually where the nerve is most superficial. Sometimes pain is referred to the region of the skin supplied by a sensory or mixed nerve, such as pain at the medial border of the wrist or in the little finger in the ulnar nerve involved. In such cases, the ulnar nerve will tender on palpation just above the elbow. A type 1 reaction with intense involvement of the facial plaque candidate fit for oral steroids. BT Hansen's on a palms with a type 1 reaction. Motor disturbances and the nerves most at the risk are usually ulnar nerve causing the claw hand. The lateral popliteal nerve involving causing the foot drop. Involvement. Lateral popliteal nerve involvement causing the foot drop, whereas the facial nerve causing the facial palsy. Facial palsy is most likely to occur if there is a lesion on the one cheek. This paralysis are likely to be permanent if neglected or incorrectly treated, but will recover with a correct and prompt treatment. The cause of the nerve pain in an increased intraneural nerve pain is increased intraneural pressure from the edema and cellular reactions due to granuloma formation, aggravated at the sites where the swollen nerve trunk are entrapped in a bony or facial tunnels. Example, cubital tunnel and carpal tunnel. Rarely a nerve abscess may be formed, producing the fluctuant swelling attached to the affected nerve. It is usually ulnar nerve which is affected in this way, but the great auricular or a common peroneal lateral popliteal nerve also been known to be involved in isolation. Difference between a type 1 reaction and type 2 reaction. In type 2 reaction, most commonly seen in lepromatous leprosy patients and in some cases of borderline lepromatous patients. It is a generalized disease affecting skin and nerves and other organs such as joints, lymph nodes and liver. Whereas in type 1 reaction is seen in borderline spectrum and a coexisting systemic involvement is uncommon. Whereas in type 2 reaction it is a generalized disease which presents with a more systemic illness. During type 2 reactions, the patients may be ill looking. During type 1 reactions, the patient usually not, and may have raised temperature, raised ESR, and even proteinuria. The skin lesions in type 2 reaction are evanescent, while those in type 1 reaction are comparatively persistent. The lesions in type 1 reactions may have sensory loss compared with the surrounding skin, while in type 2 reaction is usually not the case. When palpated, a type 2 reaction plaque consists of confluent papules and nodules. whereas in type 1 lesion feels more homogeneous. Both the type 2 reaction and type 1 reaction lesions may ulcerate, but the smear from a type 2 lesion shows the predominantly polymorphs, while from the type 1 reaction lesion show predominantly lymphocytes. Thank you. And in the next video we will discuss about type 2 reactions and the treatment for those reactions.